Good morning and welcome everyone to today's discussion of Seinfeld. This episode today will be the Hamptons. So, who would like to start? Pick a character, pick a scene.
So I thought it was kind of funny when George came back from the pool or like from the water, and then Rachel saw him like unclothed. And then later they're having a discussion because George feels like, he didn't get to fully represent himself physically. And so then Jerry's like, oh, like the penis is like schizophrenic or something. So I thought that was like the most blatant use of a psychiatric terminology on the episode today.
Yeah, and unfortunately, not necessarily factual or medically based. So we have a few things to kind of tease apart here. Let's actually start with that low-hanging fruit, pun not intended. Schizophrenia. What's our definition? So this condition, first and foremost, needs to be recognized as a psychotic disorder. And the broad stroke here is that a psychotic disorder, any psychotic disorder, is largely defined through either clinically significant deficits in reality testing and or communication. Those, I think, are the two significant broad strokes that define the condition of psychosis. When you relate that to the actual DSM criteria, that is the defining criteria of schizophrenia, we look at five specific criteria, often referred to as the A criteria. They include two of which that are examples of breaches in reality testing. So delusions or false beliefs, or hallucinations, which are perceptual disturbances. There are two additional symptoms, disorganization of behavior, disorganization of thought process, which are also examples, albeit of significant deficits in communication, one being verbal communication, the other being nonverbal, right? So disorganized thought process, easy example of a clinically significant deficit in verbal communication, while grossly catatonic or disorganized behavior, easy example of a deficit in nonverbal communication. Right? So the first four DSM criteria of schizophrenia can kind of be subdivided along the lines of the two prominent subcategories, if you will, or parts of the diagnosis of psychosis in general. That only leaves a single remaining criterion in the DSM of schizophrenia. Anyone have a guess as to what that is? Negative symptoms. Where all of the above that we just discussed, delusions, hallucinations, grossly disorganized or catatonic behavior, disorganized speech or thought process, are all examples of something that is the pathological presence of something that at baseline should not be there, aka positive symptoms of psychosis, positive symptoms of schizophrenia. Negative symptoms are the pathological absence of something that at baseline should be there. So again, positive symptoms, the pathological presence of something that at baseline should not be there. One example, a delusion. Negative symptoms, the pathological absence of something that at baseline should not be there. Right? There's multiple examples there. For instance, anhedonia, the pathological absence of interest. Right? Any questions right now about the five major criteria of which an individual requires two to begin to rule in for schizophrenia? And oh, by the way, this also stands true for another condition called schizoaffective disorder. It's the same criteria. Any questions? One final question then for the group. Can you tell me what the deficit is neurotransmitter? What neurotransmitter that is dysregulated in schizophrenia's positive symptoms? Any one of the four.
Is it dopamine?
Exactly, right? Excess dopamine results in positive symptoms of schizophrenia. A relative deficit in dopamine, hypoactivity, results in the negative symptoms of schizophrenia. More specifically, excess or elevated levels of dopamine at the mesolimbic tract, that is the dopamine, or that dopaminergic tract of the central nervous system, results in positive symptoms, whereas the hypodopaminergic state of the mesocortical tract results in those negative symptoms, right? So for our third year clerks, you may have to know that physiology, okay? Mesolimbic, positive, mesocortical, negative, mesolimbic, excess dopamine, mesocortical, a deficit in dopamine. Questions before we get to other aspects of that scene you identified in the Hamptons? All right, another observation, that same scene. It appears to me that George Costanza and his self-image is significantly influenced by his body image. All right, and when we see this, if it were to be pathological, that is, if it were to result in clinically significant distress or impairment, that general idea, that general criterion is true in multiple psychiatric conditions. Can you name me what conditions we as psychiatrists should consider when one's feeling of self-worth is unduly influenced by body image?
There you go.
Body dysmorphic disorder is one of them.
That's definitely one of them. Body dysmorphic disorder is a clinically significant imagined defect in appearance. That's one of them. Two more.
Anorexia nervosa.
Great. Okay. When that clinically significant defect in appearance is body image itself, right? Especially weight. We call that not body dysmorphic disorder, but anorexia nervosa. And that holds true for bulimia as well. And body image is central, or a distortion of body image is central in both of those eating disorders. One more. Actually, we can leave it there. I counted eating disorders twice. And then the other thing I want to talk about briefly with that very scene, focusing again on George Costanza, is there being a culturally bound syndrome that I think this alludes to. Now, I don't think, and I will be on record as saying that George Costanza does not have this. However, shrinkage definitely allows us an open door to discuss this particular culturally bound syndrome that tends to be localized in areas around Indonesia, which does come up on shelf exams. Any guess as to what I'm referring to?
Is that a Dodd syndrome?
We got feedback there. I'm sorry, I couldn't hear you.
Is that Dodd syndrome?
It's very close to DOT. That's DHAT syndrome, which is more localized to India. It's called KORO, K-O-R-O, KORO. Right? Very similar to DOT, but unlike DOT syndrome, KORO or KORO, K-O-R-O, is shrinkage, and the idea that the individual's genitals will retract into their abdomen and result in death. This is different from Kuru, which is not going to be found on your psych shelf. Again, these culturally bound syndromes do tend to appear on shelf exams. I need you to understand clinically, however, what differentiates a culturally bound syndrome from a culturally sanctioned belief, because there's a commonality in terms of their presentation that tends to confuse clinicians and therefore medical students. Both of these conditions, whether we call them or categorize them as culturally bound or culturally sanctioned, tend to be geographically isolated. Hence, they're going to largely appear on exams, shelf exams, in that context. So that's the commonality and therefore the source of confusion. The differentiating characteristic and where you really need to focus your attention when you're looking at that clinical vignette or that clinical case is in one condition, specifically culturally bound syndromes. Within the culture, the syndrome is considered to be an abnormal behavior. And that differentiates from a culturally sanctioned belief where within that given culture, the behavior is actually sanctioned or considered to be normative. Right? So Koro is actually considered to be a culturally bound syndrome. Within areas of Indonesia, Malaysia, and China, it is considered to be abnormal. On the other hand, a culturally sanctioned belief, while also geographically isolated, would be considered normative or to be within normal limits. Right? So that's a clinical pearl. Always keep that in mind. Any other observations when we look at the scene between George and his girlfriend? Any other observations made?
At one point, Jerry said something about like a must lie situation. And so I was wondering if there's anything similar to like a must lie situation in psychiatry where it's okay to lie to your patients.
Oh, the easy answer there is no. No, it would, well, let's start off with it being unethical. However, one area where a clinician may push the boundaries, and this is not something that I think anybody needs to take out of a lecture because it is more applicable to that proverbial case by case basis. These are so esoteric, these are so random and so isolated that to talk about this without it being in the context of a case is sometimes difficult to comprehend. That said, there could be a case-based scenario where an individual does not have the capacity to make informed decisions pertaining to their health care. And a provider, whether it's a psychiatrist, an internist, or whomever, feels as though by disseminating the information, more harm will come to the patient than benefit. And that's based on their individual medical opinion. In such a case, I think a third person observer, especially one that may not be intimate with the details of the case, may look on and say, wow, that patient was just lied to. And I think that might be the easiest example. I'm sure there might be others, but again, they're so random and they're so isolated that they're kind of beyond the scope of our lecture this morning. On the other hand, let's switch roles. Are there any conditions defined through patients' lies that might appear in your shelf exam?
So we're, oh, I was say we're Nikki Korsakoff, confabulation.
Yep. Confabulation is a nice neurologic term that is basically a lie, right? So individuals with certain conditions, Korsakoff psychosis, but one example, therefore the Wernicke-Korsakoff syndrome, but one example, is when an individual due to amnesia, unfortunately cannot provide an examiner the information they are requesting. And they tend to fill in the gaps of their absent memories. And that gap filling is not necessarily truthful. That's referred to as confabulation. Mm-hmm. Any other conditions?
Malingering.
Yeah. Malingering is when an individual provides misinformation for a particular or due to a particular motivation. And that motivation must be defined through some external reward. So opiates, legal implications, lawsuit, life insurance policy, with whatever. Right? What is it called when a patient provides misinformation absent an external cause?
Factitious disorder.
Exactly. So that's another condition that would also be defined through patient misinformation. Conscious effort to deceive, but this time the motivation is not an external reward and therefore can only be an internal reward. And that's referred to as either well, usually secondary gain. Secondary gain. There's something secondary, collateral that the patient benefits from. Gain is a fancy way of saying benefit or motivation. What other scenes do you want to talk about from the Hamptons?
So I don't know if Jane actually has this, but her going around without her top on, even though it's at the beach, like I would say culturally, that's not normal or like socially acceptable. So maybe that's indicative of histrionic personality disorder. But that was like the only indication. And so I'm not completely sure.
Yeah. Well, I mean, she certainly makes a grand entrance and a grand exit. And if this appears to be a pattern of behavior, and we begin to feel, well, this is who Jane is, then we're talking about her personality. And that personality and that personality disorder, largely defined through being or needing to be the center of attention, is called histrionic personality disorder. That would definitely be in our differential diagnosis. If you had to ask a question directly to Jane, let's say she comes in with a chief complaint of dysphoria and is now part of a routine psychiatric evaluation, knowing what you know, knowing what others, her friends, provide to you, which is this scene. Do you have a question for her? Other than, of course, have you had any prior types of experiences where you may have done the same thing? Because that's getting at whether or not it's a personality disorder or not. Is there an additional question you may want to ask? Either open-ended or closed-ended?
I guess you could just ask her how it makes her feel when she's, performing those activities.
Yeah, I mean, you could go with the open-ended question. Absolutely. Let's say, which often can happen, even in psychotherapy, the individual Jane does not provide you an answer to that open-ended question. Is there something you're getting at? And therefore might be there a closed-ended question that you can then pose.
I mean, per our last conversation,
I think you're muted.
you could, I'm not, am I muted?
Now you're back now. It must have been a glitch on my end because I didn't see it come out.
You could ask her if she like derives direct sexual pleasure from removing her clothing, because maybe it's
It's exactly right. So if she doesn't offer that information through your open-ended question, and you're thinking that this may be a paraphilia, then yes, that's the exact question you want answered or you need answered. What paraphilia? If she says yes and endorses that very sentiment, what paraphilia might you consider here?
Go ahead.
Exhibitionism.
I think you dropped the mic again.
Exhibitionism.
There it is. Okay. Feel bad because again, there was a glitch and I couldn't hear you, so I made you scream that word out. So now everybody down the hall is looking at your room. That's right, exhibitionism. All right. Or again, if clinically impairing, exhibitionist disorder, which is a new terminology, new as of 2013 DSM-5. What else? Any other observations? Any other characters from the Hamptons?
I guess this episode also made me think of like psychogenic erectile dysfunction versus, like medical erectile dysfunction.
Yep. So not only might we get to a discussion of the paraphilias, which are the sexual deviancies as part of that chapter in the DSM, but also the sexual dysfunctions. Yep. Right. And by the way, that's the second chapter in the DSM. The third and final chapter that covers the spectrum of sexual disorders is called gender dysphoria. That's the third and final chapter in the DSM, which does not occur here or is not alluded to in the Hamptons. I want to stick with Jane as she and her relationship with George really does appear to be much of what everybody wants to talk about this morning. She makes this comment to George about asking him his favorite cough syrup. Anything there?
Yeah, she asked when they were driving. Yeah, you know that. Sorry. Yeah, so when they were driving out to the Hamptons, she asked what his favorite cough syrup was, and I think he said like Tussin, and then said he mixed it with like water or tonic or something. So it would suggest that is a potential drug of abuse, like a normal over-the-counter drug that you could abuse. So maybe she does have some abuse history. It's interesting that I think he just went along with it, but I don't think he really uses it the way that she would, or is hinting at least.
Yeah, the range is usually from 250 to 1500. At 250 of dextromethorphan or DXM, you're going to get largely a serotonergic type effect. So along those lines, the street slang of poor man's ecstasy or poor man's X reminds us that it's largely an empathogen at doses at or around 250 milligrams. At the higher dosing range, that higher dose of abuse of 1500, it has PCP-like effects. So it works more along NMDA receptor. And there, again, street slang to allow you to remember that other pole of the dosing range is the term robo-tripping. So in either case, if you remember those slang terms, you could remember that there's actually a dosing range that you get different effects, different receptor affinity of DXM. Well, what I've also found interesting, just kind of glancing at this rather quickly, is that another street slang just so happens to be velvet, which is totally irrelevant unless you're a Seinfeld fan, because there's at least 2 episodes in which that term is actually central to a Seinfeld theme. One of which happens to be a subplot of George, albeit in a different episode. So a little bit outside of the context of our discussion of the Hamptons this morning, but I just thought it was interesting that velvet just so happens to be another slang term for DXM and DXM abuse. All right, getting towards the bottom of the hour. Any final scenes you'd like to discuss? The only other scene I wanted to bring up was Kramer and what he does. If what he does with those lobster traps is part of a pervasive pattern of behavior that results in clinically significant distress for Kramer, something to consider here.
I mean, I guess if we're considering this either just poaching or stealing, it could be, I mean, viewed as either kleptomania, or if you're taking this in the context of violating the rights of others, then you're thinking a little more along the lines of antisocial.
Yeah, that's exactly at the very top of the discussion and the top of the differential. And that's exactly what the shelf question writer is going to want you to kind of decipher. The fact that Kramer prepares and eats the food would really allow this to be, I think, discussed more in the context of antisocial personality. Again, if pervasive. On the other hand, if he simply discarded them, if the act of stealing were the focus and not the benefits from the theft or of the theft, then we're talking about kleptomania. So be careful, read your clinical vignette closely on your shelf exam. Individuals who steal and individuals whose stealing is clinically significant often have a differential of antisocial personality versus kleptomania. In kleptomania, it's the behavior or act itself that is the goal. Therefore, what is stolen is of little value to the individual. That does not appear to be the case here. So if Kramer's behavior is part of a pervasive pattern, then kleptomania is unlikely, and antisocial personality, as defined through that blatant disregard for others' rights, appears to be, or would appear to be, the single best answer. All right. Any final thoughts on the Hamptons? All right, we'll leave it there. We will convene in the conference room and begin table rounds at about 8:30. See everybody there.